At the moment, we can't hear you. Sorry, interject.
Apologies, I just I said some
Perfect.
really good stuff there as well. My name is Phill Pearce. Thank you very much, Professor Porter. I'm a general surgeon based at John Radcliffe, and an RAF surgeon based within the Royal Centre for Defence Medicine at Birmingham. I'm going to talk about damage control surgery in the austere environment, and there will be some slightly technical surgical talk to this, but the idea is not really to go too deeply into technicals, but more to talk about those considerations and those adaptations that surgeons and other clinicians might need to think about when they're in the slightly more austere environment. Disclaimers and disclosures. So as a first disclaimer, these views are largely representative of mine and not necessarily representative of any of my employees, civilian or military. I'm purposely trying to separate military and austere in these circumstances, and that not all military environments are austere, not all austere environments are military. And as I'll touch upon later on, austerity in this setting is very much a relative thing. I don't have any disclosures to make other than that my 2 children are putting themselves to bed upstairs and are under pain of death not to come down and disturb me. So fingers crossed that won't happen. So I'm going to talk really about the what and the why of damage control, what it is and largely why it is, and then talk a bit about the history and how it's evolved. And I think that's important because it will put it into context of what we do it and really why we do it, and perhaps also consider why we shouldn't do it. I'm going to briefly touch about damage control resuscitation because really the two are intrinsically linked and it's slightly artificial to try and separate them. I'm not going to go into great depth of detail about that because that's I think beyond the scope of this webinar, and I know it's been touched upon in the others, and that Dave Naumann did an excellent job of talking about some of that only a few weeks ago. I'm then going to talk about how damage control surgery would work more within a home setting, and particularly to illustrate the steps in that process, and to look at how things may change then if you're in slightly austere circumstances. But then you start the important stuff of talking about actually what is austerity, what does that mean, and what considerations we need to make, and how would you conduct our DCS when we're away from home. Finally, I'll touch upon some of those ethical considerations, and they very much are considerations. I don't have all the answers to those, I'm afraid, but they are things for people to make sure that they are aware of and cognizant of if they're aware doing any sort of deployed action, be that military or with an NGO. So no talk on damage control surgery goes without some sort of naval reference. For anyone who's particularly into their ships, this is the USS Samuel B. Johnson, which was a frigate in the US Navy, and in 1988, in April, it was hit by Iranian mine in the Persian Gulf. And the crew spent about 5 hours putting out fires, blocking off compartments, during which time the ship remained entirely mission and combat capable, and actually didn't get taken up off the sea and undergo its formal repairs until July that year. And that's really a pretty good analogy for what we think about the damage control, which is, in this case, from the maritime description, is the capacity of a ship to avoid damage and to maintain mission integrity, I should say. And damage control surgery is really that same approach. So it's abbreviated surgery. It's not doing everything that we might need to do to repair exactly what needs to be repaired. But it's all about allowing physiological correction to maintain mission integrity. And mission integrity in this setting really means to keep that patient alive. So the history of damage control is quite important, and it's a relatively recent one. Pringle, he of the famous manoeuvre, first described packing the liver back in about 1902. And it was relatively common up until the Second World War, but generally most of the packing that was done was actually into liver injuries, and it was really liver injuries that started this all off. And it was sort of thought of as a evidence of surgical incompetence, partly because it probably didn't help a great deal. And whilst I don't think I've ever packed into a liver myself, I can see that it would be fairly catastrophic and not very helpful. And interestingly, perihepatic packing and packing around it was seen very much as a last resort and something that only that non-technical surgeons couldn't do. It was only later in the 20th century that the use of packing was really started to be used as seen as a useful thing, mostly for that non-mechanical bleeding, and is recognised that in a subset, particularly of unwell trauma patients, there was bleeding coming that they couldn't control no other way, and that packing seemed to do the job. And this was the first description, really, of the staged laparotomy in which a packing was done for tamponade with a return to theatre at another date. The abbreviated laparotomy was seen almost as a side effect of this. So the first approach was to do a staged laparotomy, so to pack, give that bleeding time to stop, and then come back. And actually, the first couple of papers that talk about this actually realized almost by accident that by doing that first shorter operation, they got better outcomes by abbreviating it rather than just staging it. And I really love this quote. This is from the Birch paper, when they said that abbreviated laparotomy, as it was still referred to at this point, was a rational approach to an apparently hopeless situation, and that it sort of made sense when there wasn't much else to do. And in 1993 is when the whole damage control surgery thing properly started, and when it was defined. And the reason that the term damage control was used came back to Bill Schwab, one of the authors on this paper, who was ex-Navy himself. And they very much defined it in ways that I'll speak about in a moment. And after this point, its use became far more common and was really advocated in the context of a greater number of patients coming in with ballistic injuries. And they were multi-visceral penetrating injuries from larger caliber, high muzzle velocity, and often semi-automatic or automatic weapons. These were really sick patients that damage control was seen to be effective for. And it was this paper that they first defined it into something that we know it as today, and that's really 3 phases. I'll talk in a moment about the 2 at either end, but the 3 phases effectively are the first phase, damage control surgery 1, which is that immediate laparotomy, and I'm going to focus on the laparotomy for the time being, which does 2 things really, and that's controlling the hemorrhage and controlling the contamination. So stopping the 2 things that a patient is going to die from very quickly, with hemorrhage being the main one, followed by temporary abdominal closure, and then transfer to the ITU. And in the ITU, the main goal was resuscitating to improve their hemodynamics, to correct the hypothermia, the acidosis, and the coagulopathy. And then finally, stage 3 was reoperation and definitive repair of those injuries, and ideally closure of the abdomen. Latterly, you may see people also talk about DCS0, which is effectively the pre-hospital stage, or that first ED stage, and also DCS4, which is more definitive abdominal surgery and often reconstruction down the line, particularly when we've had complex open abdomens. Damage control resuscitation has actually been a more recent concept that's followed on from surgery. Effectively, as we've realised that those exacerbating factors of hemorrhagic shock, the so-called lethal triad, acidosis, hypothermia, and coagulopathy, are often very present in those sick patients, and probably present more early than we thought. And the damage control resuscitation strategy was to target those specifically, so that whilst damage control surgery can address the mechanical bleeding, it's really the resuscitation that targets that non-surgical bleeding, which probably starts earlier than we thought. The major tenets of it are avoidance of crystalloid. So for a long time, the mainstay of trauma resuscitation, this is evidenced by sort of early editions of ATLS, was large volumes of crystalloid to promote hemodynamic volume effectively, but without any clotting or oxygen carrying capacity. So avoidance of that, and instead using blood products as necessary. And then thirdly, and slightly cautiously, I'm saying permissive hypotension. The reason I'm slightly cautious in permissive hypertension is that whilst it is certainly an important aspect of damage control resuscitation, its role, particularly in the austere setting, is a little bit less certain, and that is partly perhaps because sometimes of the timelines involved, and partly because some of the injuries involved, particularly massive head injuries and blast injuries, where the role of permissive hypertension is not quite certain. I think one important point to make whenever we talk about permissive hypertension is that it is not a goal. It is something that we can tolerate if necessary. So I apologize, this picture didn't look quite as nicely as I'd hoped. This is from Mark Midwinter's paper some time ago, which talks about where we are currently and where we're looking to be with the combination of damage control surgery and damage control resuscitation. And the idea being that either at present or in the recent past, we looked particularly to have this period of protocolized resuscitation, followed by damage control surgery, then a return to critical care and resuscitation afterwards, with the hope that increasingly we are looking towards integrating those things, as we now have what the military sometimes will refer to as right turn resuscitation. So that is effectively missing that initial arrival into the emergency department and going straight to an operation, and having resuscitation going on as we do it, and with the two things as a combined effort. The other idea of this integrated approach is that this is tailored therapy, which is individualized to the patients and their particularly resuscitative needs. And this is all very well and good, and it's what we should all aim for. However, this is complicated, and I think a good analogy for this is an F1 team. And that integrated approach to delivering synchronous damage control surgery and effective damage control resuscitation only works with a large or relatively large, well-resourced, well-trained team. The size is perhaps not the important thing, but it's everyone being entirely well aware of their roles and having the equipment and, importantly, the products to deliver what they need to. So, what are the indications for damage control surgery? So, again, it remains slightly contentious and it remains slightly unknown, and there's still a lot of work to go as to who exactly we should damage control and perhaps who we shouldn't damage control. This suggestion was from Moore in '98, who gave quite easy to follow and binary ideas for patients that should be damage controlled. So an ISS of more than 25, which is nice in principle, but I, for one, am not unable to, in real time, calculate ISS, and I don't know many people that do. A blood pressure of less than 70 seems reasonable, but we all know that patients will have low blood pressures and perhaps respond to proper product resuscitation. And then core temperature less than 34 and a pH of 7.1. I'm not saying that any of these are certainly contraindication of damage control surgery, but that it is probably needs a little bit more judgment than that. And actually, this paper from Rotondo, which actually slightly earlier than the Moore paper, broke up into three categories, really. So those conditions, complexes, and critical factors which predispose to the need for damage control surgery. And these allow just a little bit more judgment, a little bit more nuance. So patients with high energy blunt trauma who have multiple penetrating torso injuries, clearly who have hemodynamic instability is really not something that people argue with, but that probably needs to be a prolonged thing that's not responding. And then, as I said, the clinically evident coagulopathy or presenting coagulopathy. The other thing, and this is really where damage control surgery first evolved from in the late 90s, was that multi-visceral and complex abdominal injury, where particularly concurrent vascular and viscous injury. And then again, those same critical factors that Moore mentioned, so metabolic acidosis, hypothermia, coagulopathy, and the use of massive transfusion. Now, often many of these things will coexist, and many of us will know from a sort of a Gestalt picture of those patients who are likely to need damage control. But what we don't have is a clear on and off button for those that do, and really the requirement is for ongoing communication and ongoing reassessment. I think the easiest way that I've summed it up for those patients that have extreme physiology, so patients who are obviously very unwell, those patients whose anatomy perhaps whose physiology is perhaps not that bad, but have extreme anatomy in that they have such an injury burden that even if their physiology is not too bad now, it inevitably will become so, and that definitive surgery is probably not possible. And the third reason is practical impossibility, and that's something that particularly may be the case within an austere setting, that simply getting the job done and fulfilling that definitive surgery is not impossible. So DCS at home, how does it work and what are the steps? So ideally at home it starts pre-hospitally. So that depends very much whereabouts in the world or whereabouts in the country you are. And it relies upon two things really. So the pre-hospital skill set and equipment, and the pre-hospital products, if that's to be delivered properly. And many places won't have those. There are huge swathes of the world where either no pre-hospital care system exists, or if it does, it's just someone driving. Now, there's an ongoing debate, of course, about stay and play or scoop and run, and that's not something I'm going to enter at the moment. But even both of those strategies still rely upon there being some sort of skill set and some sort of basic resuscitative maneuvers. And without those things, in a particular austere setting, you may not be onto winner anyway. The next stage is within the emergency department. Again, that relies upon products. It relies upon equipment, be that lines, be that surgical equipment, be it simple sutures, and it relies upon imaging. Now, I'm personally not going to talk about CT scanning, but we all know that there are useful adjuncts to our damage control process and to our decision-making process, be that simple X-rays or be that ultrasound in the form of a fast scan. Next is move to theatre, and of course this is really, really reliant on a great number of factors, but particularly kit. Within the austere environment, you simply may not have the kit that you need, and austerity, as I'll talk about, can vary greatly. The skill set at home is probably to be found somewhere, and here in the UK, our trauma skill set varies from hospital to hospital, from city to city, and within each hospital will vary from night to night depending on who's on call. But largely, you know that there will always be an opportunity to phone a friend, and that even if the skill set's not present there is probably an appropriate skill mix somewhere around you if you need to. That may not be the case within the austere environment. And again, within theatre, within the damage control setting, we really are reliant on products and their availability. Next, we talk about the move to ITU. That's still dependent on quite a lot of resource. So there needs to be capacity in the ITU. There needs to be enough beds, and ideally beds and staff for that patient to go to afterwards. There needs to be equipment. Yes, that will include, or it's likely to include, a ventilator and anesthetic machine, but will also include quite a lot of invasive monitoring, ideally, and again, products for ongoing resuscitation. And the last few steps, I'm going to skip forward a little bit. So that's return to theatre with the same resources required above, return to ITU, and potentially that cycle can continue for some time. And then the ward, and then importantly, rehabilitation. And actually, with our damage control patients and our severely injured patients, unless they've got that rehab at the end, there's a possibility that what are we trying to do for them? Because quality of life without that rehab may really not be that good. So I'm going to skip a little bit now onto the surgical aspects of this. I'm going to focus mostly on the laparotomy because that's what I do. And we're going to talk about some of the basic techniques that are the same for damage control surgery in the UK, but also look at the adaptations that we could do within a slightly more austere environment. Key to start is really the initial things before any cut is made, and that is positioning the patient, preparing, and that's preparing the team, and again having products in the room with a suitable plan for them. Patient needs positioned accordingly. I think this is fairly now well understood that everyone should have maximal exposure, and even with a laparotomy, there should certainly be exposure onto the chest, neck, and ideally onto the groins in case vein is needed. And this may not be possible depending on where you are. This looks like it's all very straightforward, but actually you need a table that's about the right size and shape. You need to have ideally drapes to provide some sort of sterile fluid and sterile field, and you need enough room to be able to get around the patient and for delivery, to be able to deliver the care that you need to. It all sounds like simple stuff, but may not be possible if you're in the back room of a restaurant. And then just to talk about the basics, first is incision. That incision needs to be long. It needs to be able to do the job ideally from the start, and it can always be extended. Many of us, general surgery in the UK, will have a lot of our practice may be minimally invasive, and this is not the type of minimally invasive surgery. Remember that a laparotomy wound heals from side to side, not from end to end, so making it a bit longer won't make a great deal of difference. And then packing, and then a pause, ideally to allow the patient to catch up. I was going to talk a little bit about packing because it's a particular bugbear of mine, because I both hear and see it being done badly. The first move upon opening an abdomen, particularly once full of blood, is to try and evacuate that clot. This is probably best done with a hand or with a swab, trying to scoop things out, because trying to suck it out will take forever, and if it's all clotted, it's not going to work. And only when that clot is out can the abdomen be packed properly. But in doing that packing, it really needs to be deliberate and it needs to be methodical. This is just obviously a cartoon of a packed liver. But what you can see is that the package, firstly, they need to be put in nice order. They need to be ideally counted in. They can, the exact count at the end of it may well be inaccurate, and probably doesn't matter as long as they all come out at another time. But importantly, they should be placed in deliberate matter to deliver an effect. If any of you look on YouTube for videos of abdomens being unpacked, you'll see them being thrown around in no particular place with very little effect. And if you are in a resource constrained environment, and I've had this said to me that we're out of packs. And actually, if you're putting them in and they're not doing the job, and then they're just soaking, flop around, then they come back out, well, they've done nothing for you at all, and that maneuver has been wasted and means that you may need to stir the clot again. So be deliberate and be methodical in that packing. So the two main roles of damage control surgery are to control hemorrhage and control contamination. So vascular control can be achieved effectively by one of three ways, either through ligation of anything that can be ligated. And so that's a great deal of vessels up into including the celiac. Also, the SMA shouldn't be, the external iliac shouldn't be, but quite a lot of else is up for fair game to be ligated if it's really a problem. That said, a great deal of vessels, particularly veins and major arteries, can be repaired. I'm not going to go into the techniques and the exposures for that. But that's largely the same both here and abroad. The things that may change is that actually they may not have the suture that you want. And if there's a particular curve on a particular needle on a particular 3.0 PDS that you like to do for this particular repair, well, you may not have that. And having a bit of flexibility in your thinking in what you use is important. Shunting is an option for those vessels, but it should be realized that it isn't without risk. In that shunts can quite easily become dislodged, particularly if you're looking at someone that may well be evacuated. And also they can, whatever vessel they're in, they could actually damage it. And then if you do go to reconstruct on a line, you've got less vessel than you had before. Ideally, though, that you can sort of use whatever tube that fits, be that a specific off-the-shelf shunt or an NG tube or whatever else it is, or feeding tube, whatever else you've got. And that needs to be secured, probably with ties, but ideally without injuring the underlying vessel. Solid organs, so the liver we mentioned packing, but those of them that can be taken out probably should be taken out. There's no role for trying to repair spleens or repair kidneys within a damage control setting. GI injury is very simple. There are two options for most GI injuries, which are either repair or resect, and repairs don't necessarily need to be very pretty. Often the repair that's done initially can be sort of a continuous whip stitch, closed with drains left it. Resections, so obviously within the true damage control surgery setting, no anastomosis should be formed, and also there shouldn't be any effort to make a stoma at this point. And really the idea should be to chop and drop, so resect injured segments if they can't be repaired, and then drop them back into the abdomen. At home, nearly all these are going to be done with a stapler, but well, surprise, surprise, if you're in the austere setting, you very well may not have a stapler, and you're back to old school BSS stuff of using bowel clamps if you have them, but perhaps just a knife and scissors and a suture. And actually, probably the quickest way then to drop those bowel ends back in is with some umbilical or some nylon tape tied around the bowel ends. You will get a little bit of dieback if it's tight enough to constrict them, and will need to debride them when you reconstruct them, but it works quite effectively. Complex GI injuries can be very difficult to manage. So those to the pancreas, to the duodenum and the bile duct. Sometimes they can just be left alone entirely, and some simple duodenal injuries can just be repaired. But the key, particularly if you're a surgeon that doesn't deal with these injuries, or particularly just with these areas of the body in their elective or emergency practice, is to carefully consider the physiology, because doing any sort of repair for them will probably take longer than you think. Make sure you don't make anything worse and do any harm. If you're not familiar at all with pancreatic dissections, it's quite easy to wander into the portal vein. Don't invent operations. We would all love to have operations named after us. Unfortunately, I think most of the clever things have already been thought of. If it doesn't exist, it's probably for a reason. So for an awful lot of these injuries, if there's nothing that is that's bleeding up into your face and doesn't need immediate fixing, if you're unsure, a lot of them can be drained. And if you don't have drains, well, the Foley catheter is your friend, and I think nearly everywhere will have these used for everything. And certainly when I've been overseas, everywhere has got Foley catheters, and they can be used for a wide variety of things. So be that as a GI drain, in the neck. I think I've never done this. I know it's one of everyone's favorite things to talk about, doing a Foley catheter. I'm still waiting for the opportunity. Into a liver. or into a heart. Again, I haven't done this. I don't advocate for it because I'm always worried that it would pull something out. But I'm sure someone could write a book of 101 uses of trauma for a Foley catheter. Temporary abdominal closure is a very important part of the damage control process, and that's for two reasons, really. One is this is almost certainly going to be quicker than your fascial and skin closure. And secondly is for avoidance of intra-abdominal hypertension or avoidance of excessive intra-abdominal hypertension. If the abdomen is packed, then actually we want a little bit of intra-abdominal hypertension because that's what's going to stop that venous and portal bleeding. But what we don't want is the patient to develop abdominal compartment syndrome. The idea of temporary abdominal closure is one that protects the viscera. It controls the heat loss and prevents desiccation, and ideally manages the effluent. The last one is probably the least important, but is particularly useful if you've got if you're low on staffing. What you don't want is your ward staff spending all their time just cleaning up effluent from a wound. The number of ways to do it that range from the incredibly simple. So these are just towel clips. Fairly brutal way of doing it. The same thing could be achieved with a running suture. One of the problems with this is that firstly you do have a degree of closure, and so your risk of abdominal compartment is probably slightly higher because it's going to be quite tight to get closed. Secondly, you're going to have fluid probably spilling up from underneath, and also there's a concern that you could still have a little bit of bowel that could slip between either the towel clips or the sutures. At the other end of the spectrum are the commercially off-the-shelf devices like this. So this is the Austere, which many of you may use in your practice in the UK, which is a nice bit of kit and has everything with it, but is both quite cumbersome if you're taking the whole kit with you overseas, or is quite expensive if you're working somewhere that doesn't have the money to pay for it. And actually, what many of us will do is something in the middle, either a Bogota bag. So this is simply a sterile fluid bag or something similar, which is stitched to the skin edge. One of the problems with the Bogota bag, again, it doesn't manage the fluid very well, and it's actually quite laborious and takes quite a long time, as you can see, to stitch around the edge properly. Or we can do the sandwich technique, and this is very well established and used in some UK centres in place of the Austere because it's quite a lot cheaper, and that still a protective covering is placed over the bowel before towels are placed, and then drains, as you can see in the middle, and then an additional adhesive layer put over the top to allow drainage. This can just be connected up to the wall suction if necessary, and then the suction can be changed. And actually, this is a nice system that was published by Rob Faulkner a few years ago. Basically a similar thing to a sandwich, except they use a one-way valve and a chest drain such that they can apply a bit of suction, and because of a one-way valve, it doesn't need to be suctioned all the time, so it's useful for transporting patients. Now, I focus a bit on the laparotomy there, but of course, damage control surgery is not all within the abdomen at all, and the same principles can be applied to both the chest and limbs and to junctional trauma, so the neck, the groin, the axilla, and of course to the head. Of course, with all these things, there needs to be the requisite skill set in order to achieve those skills. So then, how do we define austerity? Knowing what we do in the UK, how do we change what we do if we're in a slightly more austere environment? Well, I think it really depends what the austere environment is, and there's a great number of factors to that. Firstly, you need to consider your facilities. What is your operating theatre like? What is your recess like? Do you have space to things? What is the flow of patients going to be? Secondly, within your facilities, what is your equipment? Do you have an actual operating table? Do you have lights that work? Do you have diathermy machines? Do you have ultrasound? Do you have some sort of infuser? And it may well be that you have all those things, but actually things are austere because you don't have products. And that really is key, as I've shown throughout all the steps, is that it's very difficult to deliver proper damage control resuscitation, and with it damage control surgery, if you don't have the blood products to do it. Very important, particularly within the austere environment, as I've said, is the skill set. And if you're particularly working within a small team, it becomes very difficult for any one person to have the requisite teams. And so you need to look at both the skill set and the skill mix for who's around you and what can be realistically achieved. Along with the products and equipment, we need to think about the logistics. So if you don't have the products now, what is your supply chain and where could you get some from? And in a similar vein, what is your throughput going to be? Where can you evacuate patients, and be those UK patients or patients where you are, depending on whatever population you're serving? What is the exit plan for those patients, and where will they go, and what will the facilities be like at the other side? So then delivering DCS in the austere environment, really, I think of it as two two things that really consider. First is defining your austerity, and then secondly is defining your mission. And again, I'm personally staying away from the military side of things here, but whatever you are out there, I think there needs to be a careful consideration of what it is that you are trying to achieve, and then how do you overcome or avoid the mismatch that you get with your austerity. And part of the way you do that is with planning. So with your planning, you need to have an idea of what the patient cohort is going to be. So what age they're going to be. Are you going to have to deal with children? Are you going to have to deal with pregnant women? Or is it all going to be young males? What sort of injuries are you looking at? If indeed you are talking about all just injuries, there may also be so non-battle disease, so be that emergency general surgery things and pregnancy-related problems. But if you are talking about injuries, are you looking at stabbings? Are you looking at crush injuries because this is an earthquake? Are you looking at explosive injuries? You need to think very carefully about your skill set and your skill mix. So does that mean either changing or you're augmenting your team, or is it simply a sensible discussion between this is who we are, this is what we can do, and this is what we cannot do? And with that, you can look at what are the rate limiting steps and to what extent those things can be overcome. What are our pinch points going to be? What do we need to change? Now, can that be by upskilling people? Can it be by changing our logistic network and getting things in place? Once those are sorted, you can think about standard operating procedures, SOPs, so that when this patient comes in, this is how we normally do it in the UK or at home, but actually this is how we're going to do things in our Austere setting, and those things may well be slightly different. And with that, always have a plan B and a plan C and a plan D. An important point to consider, particularly well, both at home and within the Austere environment, is damage control surgery really required at all? Because importantly, damage control surgery, and talking about the laparotomy here in particular, it comes with a cost to the patient. So inevitably there is a prolonged ileus because they may well not be joined up. There's a high risk of incisional hernia, and there's a much higher risk of ECF or enterocutaneous fistulae from bowel injury. And DCS, of course, comes with the cost to whatever hospital or centre or unit or mission you're on, and that patients are inevitably going to be on ITU longer, and they're going to need to return to theatre longer, and that all takes up resources. This suggests that there is an overuse of DCS, and this is actually from the US Centre, and they showed that there probably was a significant overuse of DCS. There's no ideal rate, although this study suggested they thought it should be about 20%, and that was based on a panel voting what was appropriate and inappropriate of damage control surgery for laparotomy. And it's very easy to discuss this in retrospect, and if it's 2 in the morning and you're doing a case and you're unsure, no one is going to criticize you for damage controlling in what is inevitably safer. But if you're in an austere circumstance and your logistics are a bit limited, then you need to be a little bit more careful on what is the ongoing issue and what is the ongoing effect of your decision to damage control going to be, not just upon this patient, but on future patients and your capacity to keep going. So ethical considerations. These are generally not something we need to think about too much when we're looking at our practice at home. But within the austere environment, you really need to think about what is the focus going to be. And it may not be about the continuity of care for a particular patient. It may not be making sure that that patient has the pre-hospital to rehab pathway, but actually about throughput, because you may have a large number of patients coming through and you can't do anything if your ward and your ITU are full. You may need to triage patients based on your resource. So if you really don't have any products, you may need to think about what you can and can't do. And the severely injured patient with multivisceral, multivascular trauma is going to take up a lot of your products. And if you only have 2 units of blood left, an argument can be made to should you try and tackle that at all. And with that, you may need to accept modified standards of care, which are slightly different to what you'd be used to at home. Any intervention used should ideally be simple. It should fail well. It should ideally be individualized well, although I've already talked about SOPs are important. And incredibly importantly, it should be to improve survivability. There is no intervention that should be done because it can be. Rather, it should be done with aim to affect survivability. And ideally, if possible, should be resource cheap. The ethical considerations, of course, need to come alongside awareness, and that needs to be of whatever legal situation you're operating within and the medical rules of engagement.
important to take into account as the local healthcare and the infrastructure. So again, what is the exit pathway from where you are? Is the patient going to be offered, if they are discharged from you, are they going to be offered local follow-up and local reconstruction if necessary? And you must also be aware that there are some cultural differences in how some things are accepted. Stoma, for example, that in some populations are very much frowned upon, and which patients may not tolerate. So to summarize, my two biggest points really are to try and define your mission and to define your austerity. What is it you don't have and what are the rate limiting steps? Once you know that, you can think about addressing the mismatch, but do so whilst maintaining situational awareness and think about what your exit plan is and what your plan B is. And really importantly, particularly if you're in the Austere team and Austere environment and you perhaps have a small team, you may not be able to do anything, and so importantly, do no harm. Thank you.
Phil, that was absolutely excellent. Having been privileged to watch damage control and damage control surgery evolve in the last few decades, particularly with the military, I know all of those facets of information that you've shared with us tonight. And whatever your background experience, that was put very succinctly and clearly, and I know was extremely valuable. If there are any questions, please, from the participants, do please put them on the chat screen. At the moment, there's very little there, but I'd like to ask one or two questions, if I may. In terms of training for damage control surgery and this type of trauma surgery, say if I was a general surgeon in a district general hospital, are there any specific courses that I could go on?
Yes, so there are also the DSTS course is excellent, and is a very good. It is quite UK based and accepts sort of UK standards of care, but goes through everything within the chest and abdomen and the vascular approaches particularly. I believe it's closed at the moment, but there used to be what's called the STAY course, or trauma within the austere environment course, but which is run by David Knott, who some of you will know as sort of perhaps the best known austere surgeon in the UK. He does, I think there is now another course, the Hostile Environment Surgical Course, or HEST, which I think is run by the David Knott Foundation, which I know again is excellent and focuses on some of the reconstruction down the line as well. I think my biggest advice, and I do this quite a lot for trainees, there is now for general surgeons at least, there is discussion that you can do trauma training in the final 2 years and effectively CCT in trauma. And whilst there may be some merit in that, I would suggest that a lot of trauma surgery is good general surgery done quickly and reliant on very good decision making. And actually the techniques for trauma surgery often come from elective surgery. So I think really what's important for trainees, particularly even if they're working DGHs, is for whatever they're doing, think about how would I use this approach within a trauma setting, or having seen that vessel or that thing, and I've seen the exposure done in elective surgery to get to that, how would I do that in a trauma setting? And nearly all the complicated trauma maneuvers, which are not touched on today, are all derived from elective practice.
Thank you very much. I know the military had the concept of right turn resuscitation, where military patients coming in were taken straight to the operating theatre. Do you think that's something we should consider? I mean, is it something you consider, for example, at John Radcliffe?
It's very difficult, I'd say. I haven't seen John, so I did most of my training in Royal London, and I would say that they were closer there. I think there are other people on the call that have worked there as well. We'll know that the practicalities of it are very difficult, actually. And what is different from military practice is actually the more people you have involved, as I showed the F1 team earlier on, that actually beyond a certain point, yes, you get more people, but the complexity, I think, increases. And you end up with these inevitable pit stops
for something, and then you sometimes lose momentum a little bit on it. And we don't quite have the same injury pattern that requires a damage control, the right turn resuscitation. That a lot of that was derived from high amputees with massive catastrophic external hemorrhage. We don't get quite so many of those patients. So I think there is certainly a role for it. I don't know of any trauma systems in the UK as yet. There may be people out there shouting at their computers because they know better, but I don't have any trauma systems out there that are quite developed enough or slick enough for that to be quite there yet. So I think some of them are close, but I don't have anywhere that would be able to get them straight up to them yet. And that partly you're very reliant on the communications between the pre-hospital and the hospital system to have things in place.
Yeah, thank you very much. You mentioned about leaving the abdomen open. Is there a sort of time limit? I mean, your patient may have some sort of temporary closure, but is there a time limit when it's no longer possible to close the abdomen?
It certainly gets harder and harder. So I've not talked about the open abdomen specifically, but so in terms of taking the patient back, I wouldn't be too prescriptive on when to go back. It's really when the physiology dictates and what the initial injuries were. People say 24, 48 hours, but sometimes it can be earlier than that if the patient has been physiologically restored. It gets harder and harder to close the abdomen as things go, and so an effort should be made at each time to close the abdomen if it's doable, because as you go down, you get past a few days that you get fascial that retracts, and then you end up doing complicated maneuvers in order to get the abdomen closed. So could that be that tension sutures or mesh mediated closure, and then you end up looking down the line at component separation. So there's no, you have to be dictated by the physiology and by the abdomen, and sometimes there is no way that abdomen is going to get closed on that admission, and you have to accept an intentional ventral hernia, sometimes with a mesh over the top that gets the skin graft down the line. But that needs to be probably recognised earlier on that we're not going to get this closed. But there is no, ideally at the first sitting, but I think you also just need to be pragmatic. The patient needs to be alive in order to have a closed abdomen.
Thank you very much. One question now submitted, anonymous attendee. It says, as a newly qualified paramedic and working rurally, would you advise some packing of an abdominal wound if bleeding cannot be controlled, or field dressing and pressure only?
I think it's not unreasonable if you had an open enough wound to get some packing into, and you really can't get bleeding from external pressure, then yes, those wounds are probably fairly unusual, to be honest, because most of your penetrating injuries, certainly in the UK, a stabbing wound generally isn't very much to pack. You'd have to have sort of a really high energy ballistic wound to have a proper cavity, but it's not at all unreasonable. If there is a space to pack and it's blood gushing out of it and you've got no options, then absolutely yes, pack it. You will not make things worse, probably.
Okay, that's the end of our submitted questions. Phil, can I say thank you very much for an excellent comprehensive presentation. For those of you who've been listening, do tell your colleagues and friends about this, because there will be a chance through our website at Trauma Care for others to pick up and see this presentation. I'd like just to now go through some closing slides and just recognise some of our corporate partners within Trauma Care. Galen, who many of you will know, who produce Penthrox, also Icarus, who have expertise in providing care in Austere environments, very relevant to what we were discussing, and also our academic partners. And I know we have some students online from some of these institutions tonight, but we are delighted to be associated with Wolverhampton University, Plymouth University, University of Sunderland, University of Central Lancaster, and Gloucester University, and in terms of training with Pro Trainings Limited. All that remains me to do is once again to thank our speaker, but also to thank you, our audience. Do please look on the Trauma Care website. I've already mentioned FIT course coming up in November, Bristol in on the 2nd and 3rd of October. And we are in the process of launching our 5-day conference at Stone, Staffordshire, for March next year. And details of the themes are now available. Ladies and gentlemen, have a wonderful evening, and thank you very much for joining us.